Hello and welcome, everybody. So this is a really important topic. Thank you so much for all of you joining us. Those of us who are practitioners, whether we're medical healthcare practitioners, coaches, we all know that when that client or patient is in rooms, we have maybe an hour with the patient or the client at most. And then what that person in front of us absorbs in that hour itself is questionable. Now, what is more powerful than the time in your office or beyond your screen in that session doesn't come from that doctor's room or from that consulting room, but rather comes from your patient's own living room. So welcome to everybody. I'm Dr. Hassina Kajee. I'm a specialist physician, medical director here at Nutrition Network. And today we're being joined by two pioneering practitioners who have transitioned from traditional clinical practice to the forefront of modern healthcare. They've moved beyond this snapshot kind of medicine, limited towards just what's visible in a single consultation, and their practice of using continuous, personalized, data-informed care actually looks at addressing the root cause of illness. So in this live that we're doing, we're actually doing it in celebration of our soon-to-launch course, Mastering Metabolic Metrics. It's going live at the end of July, so please keep an eye out for it. And in it, we go beyond theory to show you how to use real-time tracking of glucose, ketones, sleep, HRV, and more to guide precision metabolic care. So joining me today are Peter Cummings. He's an NNP and an MHP. He brings over 30 years of experience in health and human performance. He's also one of our esteemed and published, may I add, graduates at Nutrition Network's medical practitioner certification platform. Peter specializes in using home monitoring devices to facilitate remote coaching and sustainable lifestyle change. And his lecture is a practical roadmap that you don't want to miss for clinicians ready to bring this model to life. Welcome, Peter.
Thank you, Hassina.
And we also have Franziska Spritzler. Now, Franziska is having some technical difficulties, but let me introduce you to Franziska. She's a registered dietitian. She is certified in diabetes care and an education specialist. And she's also the medical science liaison at Keto Mojo. She delivers 4 of the core lectures in this training on ketone testing, glucose and glucose ketone index monitoring, clinical protocols, and implementing a continuous care model. Franziska, I'm not sure if you can hear us at all. Okay, let's just see. Okay, so Franziska's writing in the chat box to us. Unfortunately, she can't hear anything. So maybe we're going to ask her to go offline and ask our team to help her while we continue with the live so far. So Peter, I'm so sorry, Franziska, and I'm so sorry to all of you joining that you can't hear Franziska. Hopefully we get this sorted out soon. But let's go on anyway. Peter, welcome, and it's really glad that I'm really glad that you're here, that we have that hands-on practical experience that you can share with us.
Yeah, I have quite a bit of it. I've been remote coaching athletes for about 30 years now and really got into the medical fitness model because the chief medical officer of the cardiology group that wanted a medical fitness model really saw what I was doing as the future. And he still feels very strongly about that as you stated in your opening statement, that what's really going on with driving health is happening on a day-to-day, moment-by-moment basis in our patients' lives. And we need to support them and educate them and monitor them and give them feedback almost on a day-to-day basis. And these devices that really have only now recently come to market have allowed us to monitor. Well, it's almost endless what we can monitor nowadays compared to even just 10 years ago.
Awesome, Peter. So I think that's like a beautiful segue to ask you, how has your practice changed from this model, where obviously these days we have more access to more advanced technological devices in order to monitor remotely. So how has this model changed your practice, your life as a practitioner compared to the previous method of healthcare and coaching?
Well, when I first started 30 years ago, we had power meters, heart rate monitors, an online platform, and the internet. But if you recall, 30 years ago, the internet was all DSL. You needed to download a driver. Your computer needed a CD-ROM to download that driver. It didn't automatically upload. My athlete had to take their device, connect it to their computer to upload the file. And from an athlete perspective, nowadays, that's all automatic. They get a workout in their device written by me. It controls their smart trainers. As soon as they're done, it goes up to the platform. From the medical fitness component, as I mentioned, even 10 years ago, when I got back into the medical fitness world, I was dealing with brick and mortar. And as I mentioned, the chief medical officer envisioned telemedicine and use of these devices as the future. Unfortunately, 10 years ago, I had to tell him those devices really didn't exist at any level that we could bring it to a patient-facing model. But he wanted me to prepare the model for exactly that. And little by little, we started to see CGMs, blood pressure cuffs that patients couldn't report, HIPAA-compliant texting capabilities. So we were starting to get stuff like that. And now today we've got Bluetooth-enabled scales, blood pressure cuffs, CGMs, glucose monitors. I got my Oura Ring that you and I have discussed so many times. It all goes into, it goes into a platform for me. And as the patients live their life, get on their scale, take their blood pressure, download their Oura Rings, I get to look at their sleep. I get to look at their stress. I get to look at whether they were active yesterday. What time did they get to bed? And it's just amazing how much it's changed.
Thanks so much, Peter. And I just want to say thank you. Franziska is back with us. You can hear us, Franziska.
I am. I can finally hear you. I'm so happy to be here. To everyone, and I'm technical difficulties, you can't get around them sometime, but fortunately I can hear you now. Hello.
Unfortunately, it really doesn't matter, because it's just so much more valuable that we get access to you and your medical expertise. So thank you so much for joining us. So what I was just chatting to Peter about, I'm not sure if you were able to hear, was how has this practice of practicing cutting edge medicine, definitely not what we were trained to do. How has it changed your practice as a medical practitioner, from how you practiced before to how you're able to practice now?
Yeah, that's a great question. So currently I actually don't see patients. I work with Keto Mojo as medical science liaison, but for many years I ran my own practice. And there's a big difference between having to see people once every 3 months and follow with them maybe a little bit in between email and not really know what's going on with them in the meantime, unless they reach out for something, versus being able to actually be in touch with them every day, seeing their biomarkers come in and being able to intervene early on rather than just hearing about it months later and trying to backtrack to figure out at what point they got off track. So I think just having access to all of that data can be so, first of all, empowering for the patient, because they are actually doing the testing, but then they're reaching out to you as needed, but you are also working with them and seeing if you have that back and forth and you can jump in and intervene when you see that's needed.
Thanks, Franziska. Now, I just want to say, you might see me swaying a little bit. Peter spoke about exercise and the ability to look at the data in the Oura Ring and to see how active you were. We launched a beautiful module with Peter, exercise prescription. And when I studied the research on sedentary behavior, I saw how detrimental it was, and I've been moving. So I just want to bring attention to that is something that we can also track in ourselves and in our clients. But Franziska, you mentioned, this seeing people every 3 months and getting access to that data. I remember having the patients who came to me. I ran a high K unit, so it wasn't an OPD. So when I had a patient who came with a little book and had all of the data of, I tested my glucose 4 times a day. Obviously, those are the patients who are on insulin, and so it becomes something really vital for them to be tracking. But at this point, we have a whole global population of people who are not diabetic, they're pre-diabetic, or it's preventative. But for those people who don't track, who kind of, they've heard about the CGM, it's like this kind of alien thing, and everyone's becoming a robot and implanting devices. Let's just demystify it for them a little bit, and let's talk about why it's not enough. What's the risk of waiting to see your practitioner every 3 months and acting only at that point?
Yeah, well, I think the risk is that you see disease progression because the patient may get off track, as I mentioned before, and not have the practitioner there to notice it. They may feel that they don't have ability to contact you until your next appointment. So they continue to kind of spiral down and figure, okay, I'll talk to my doctor about it when I see them, or my practitioner, my dietitian, whoever they're seeing. The risk is that they never get under good control, and prediabetes progresses to diabetes, or type 2 diabetes progresses further and causes organ damage or the need for multiple medications, to mention to solve something that can be solved with dietary and other lifestyle methods. So I think the risk is that the patient continues to get sicker, and they also don't feel supported. So they feel less likely to reach out if they notice that something is off or wrong. I think that having that close contact and having it really be a continuous care intervention as a partnership is very important.
Thanks, Franziska. Now, as a medical practitioner, obviously the patients you're going to see mostly are those patients who are sick, who have a tertiary disease. They're diagnosed with the illness and they're on medication. Now, Peter, you mentioned something very early on when you spoke about your athletes way back when and the CD-ROM, and they had to load that. And I'm guessing that whole experience is pretty expensive. It's not going to be accessible to the large majority of people. But when it comes to, when I'm going back to my practice in healthcare and the way I used to do things, you have your diabetic patient coming to you 3 months later for their follow-up or whatever it is. And in that little follow-up time, the only information you can get is, I'm not feeling great. You check a blood glucose and you can see the blood glucose is high, and then perhaps the blood pressure is high. So, and you dip the urine and you see protein in the urine. So you're getting disease progression that you mentioned, Franziska. So when it comes to remote testing, what I'm trying to say is that archaic medicine still exists. People who are really sick, that type of medicine still exists. But now we have a population of people who are pre-diabetic, who are not on medication, and who really want to improve their outcomes. So Peter, this is probably the population you're serving now. I know you've spoken about people morbidly obese or struggling with weight. How has working with this model helped you to get that person on track as quickly as possible?
Well, there's nothing more important than being successful with a patient. If a patient is going to put the effort in, they need to see some type of value to them. And if they see that, they will continue to put the effort in. So you may not be familiar with this term Monday quarterbacking, because U.S. football takes place on Sunday. And on Monday, everybody breaks everything apart. Like they're making great headway into fixing the team's problems on Monday when the game is already over. And I kind of see remote work and the remote tools that are offered now as live in-game coaching, right? We don't wait until, the patient comes in and we find out that they gained weight and their hemoglobin A1C is higher than it was 3 months ago or 6 months ago. We can see what's going on a day-to-day basis from their glucose variability, their spikes, and talk to them in real time. So you can say, what did you just have? What did you just eat? Yeah. Well, guess what? That probably shouldn't be on your list if we're going to try and avoid glucose spikes. And this really helps the patient, that the speed of the feedback is critical. And I think that's where these devices help to teach the patient, well, they told me that a 40 milligrams increase pre and post meal was a spike, and I just saw one. What did I just eat? The patient starts to become involved in their care, because little by little you're educating them, and little by little the devices are giving them feedback that they need, and they become more of a working partner rather than someone that you're just trying to talk down to in clinic every 3 months or 6 months.
I love what you said about success, because success breeds success. There's no other. I was talking to my husband the other day about my progress in exercise and just in the things I do, and I realized my biggest motivating factor is myself or what I've achieved. So if I can do a pull-up, then tomorrow I know I can do a pull-up. So tomorrow maybe I can do 2 or 3. And so that is the motivating factor. So that success is critical. But what I was just thinking about as you spoke, Peter, is the other savings, the other benefits of being in the person's ear, like in game, you're in their ear saying, the cost saving, the mood saving, the health saving, not just the number on the scale. So that's just critical. Franziska, you talk about that, the dawn phenomenon. A lot of people who start monitoring, and I get this a lot, especially with these patients who are so motivated and they're doing everything right, they're amazing, and then they suddenly beside themselves with worry because they ate everything right, and they woke up in the morning and they tested their sugar, and their sugar is higher than it was after eating breakfast the day before. So can you just talk to those people, or talk to us around that? Why don't you, or what is the rationale behind that period that you advise not testing? And for what kind of time frame do we say to people? Like I just say, look, test it, know it, but ignore it. And in future, don't test it. Test it periodically. But what advice do you give?
Yeah, that's a great question. I give advice on people for testing both blood glucose and ketones, and I do recommend testing them both together at the same time, if possible, with 1 drop of blood. I think that testing in the morning is good because it's a baseline. You've been fasting, but you don't want to test immediately after jumping out of bed, and that's because your body still is responding to the rise in cortisol and growth hormone that are produced in the early morning hours. These are hormones that help you to get ready for the day, which is great. But what they do is they cause an increase in blood glucose, which causes an increase in insulin in people who produce insulin. And that causes ketones to go down. So if you're testing first thing when you get out of bed, you're going to see higher blood glucose and lower ketones than may reflect your true metabolic state. So what I'd say is to wait for a time period until that cortisol effects leave your system. And it's going to depend on the person how long that takes. Someone who is more insulin resistant, it's going to take longer for the effects of cortisol to clear. I recommend anywhere between about half an hour to 2 hours or even more after getting up. But it does vary from person to person. I could say every insulin resistant person should wait 2 hours to test, but that may not be the case. So what I recommend doing is for 3 days in a row, testing 3 times, testing about half an hour after you wake up, an hour, and then 2 hours or even a little bit more than that. Do it for 3 days so you can kind of detect your own pattern, and then find at what point the glucose starts to go down and the ketones start to rise again. And that is the best time for you to test. It doesn't have to be on the dot every time you test, but around that time so that you know you're not going to see, you know, a high blood glucose. Knowing that you're doing everything right and getting that type of reading can be very discouraging. And you start to wonder, you know, do I need to have a longer fast? Perhaps some people might, but for others, it is simply a matter of waiting for the cortisol and growth hormone effects to clear from the system before testing.
Thanks, Franziska. You've explained it so beautifully. And, you know, I think that when it's almost an expected thing, we should preempt this in our clients that are starting this lifestyle and monitoring, because it's a huge shock, you know, and they really are distressed when you see them. So thanks for explaining the why. And I think that's the perfect time to move on to what you talk about, the glucose ketone index, and how it can be used to optimize outcomes in chronic diseases, even psychiatric care. Can you just talk to us a little bit about that?
Sure. So the glucose ketone index is a simple ratio of glucose in the blood to beta hydroxybutyrate in the blood. But you need to compare like units. So I think in South Africa, you test blood glucose in millimoles per liter. And in many countries, that is the case. But in the US and a few other countries, we measure blood glucose in milligrams per deciliter. In order to calculate the GKI, you really need to have glucose in millimole per liter. So you do that by dividing the milligrams per deciliter value by 18. That gives you your glucose in millimole. And then you divide that by the ketones, or the beta hydroxybutyrate, in millimole to get the GKI. Now, you know, I work for Keto Mojo. If you have a Keto Mojo meter outside of the US and you use millimole, it'll automatically be calculated on the meter. If not, if you're in the US or someplace that uses milligrams per deciliter, our app, My Mojo Health, will calculate the GKI for you. But otherwise, you can do those calculations. But the GKI was originally developed by Dr. Thomas Seyfried and one of his colleagues to monitor and to personalize therapy for patients with brain cancer who are undergoing ketogenic metabolic therapy. And the lower the GKI, the more that the brain is using ketones in relationship to glucose. So lower GKI is the goal for people with glioblastoma or other high-grade gliomas. These cancer cells use glucose very effectively to grow, and that's how disease progresses. But these cells cannot use ketones. The healthy cells in the brain can use ketones. So by changing the fuel source to provide ketones for the brain, but starve the cancer cells in the brain of glucose, we can hopefully decrease progression of the disease, make it more stable, and also provide neuroprotection to the brain with the ketones, and hopefully make the cells more responsive to the traditional therapies like chemotherapy and radiation. So the GKI for the patients who are using it for glioblastoma, the goal is at 2 or less than 2, actually closer to 1 if possible. This is a very deep level of ketosis with very low glucose. It is difficult to maintain long-term. People with such a serious disease, though, with glioblastoma, has a very high mortality rate, and it's usually quite rapid. Having a very targeted ketogenic intervention is important in that regard to try to keep that GKI as low as possible. However, GKI is also being used now, as you mentioned, in psychiatry. So people with depressive disorder or anxiety or bipolar disorder. And because, again, the brain, we want to provide the brain with a better fuel. Many people, actually most people with some type of mental health condition, aren't using glucose as effectively as they could be. And ketones can step in to provide a cleaner burning fuel that also provides neuroprotection. So the goal, GKI for people following it for mental health purposes, isn't well established. It's really still being investigated and explored in studies. It's been studied much more in brain cancer, but there are some case reports, and I know that some psychiatrists recommend, I've heard anywhere from aiming for a 3 to a 5 to around 6 or lower. Actually, Dr. Lori Calabrese, who is a clinical psychiatrist, she has published several case reports of people with major depression, obsessive compulsive disorder, and other serious mental health conditions who followed a ketogenic diet, tested blood glucose and ketones, and tracked their GKI. If they kept it under 6, they often went into remission. The lower it was, the more likely they were to go into remission and have better results. But I think what's really important is to do what is possible for the patient and make it very personalized, because not everyone is going to be able to achieve these very low GKI values. Even if it may be more beneficial, we have to look at quality of life and what is realistic for a person to achieve and to be able to sustain throughout their treatment. So I just say really personalize it. And a GKI of 5 or 6 is excellent. We don't need to go very low unless you are targeting glioblastoma therapy, for hopefully helping to prevent progression of cancer. Other than that, just doing the best that you can and monitoring. As I said, if you test glucose and ketones just within a couple of minutes of each other, they need to be tested right between each other in order to have them at the same time to get the ratio. Then we can use that tool to target therapy and personalize it and adjust it as needed to those goals.
Thanks. Thank you so much, Franziska, for explaining this. And I'm just thinking about the listeners that are watching this now or later. And of course, people relate to what's relatable for them. A lot of people previously and perhaps still see the ketogenic diet as a diet that is for, it was for epileptics that were resistant, and it was for certain kinds of brain cancers like glioblastoma. And having conversations like this helps us to personalize it for the person listening. So many people are just using Ozempic with horrible side effects and cost, and they are really desperate, which is why it's one of the most researched kind of areas in weight loss. It's all about Ozempic. So we know that the need is there. And so I want to bring the conversation back to Peter, because I know, Peter, that you are seeing not just athletes now, but you're seeing just the general layperson who's struggling with obesity and, struggling to lose weight. So when you use these modalities, glucose and ketone testing, as well as all the other tracking, information that you get, what patterns do you commonly see when your clients first start tracking, and then what aha moments come from them? Because you've both spoken about kind of, handing the reins or the steering wheel back to that patient or client. Really, that's what we want to do here. We want people to be in charge of managing their own. We want to give them the tools, and it's amazing. It's an amazing tool, and I think it's the thing that's going to turn things around when people who are struggling with weight gain, pre-diabetes, have a family history. Oh, my mom died of diabetes, and I watched her go through. She had the amputation, and then it was 6 months later, and she had passed, and I nursed her, and so I know what it's like. Therefore, I never want to be on insulin. That's a recurrent story. What do you see, Peter, in your clients that use these the glucose and ketones that give them back their power?
Well, the coach in me uses what you just mentioned, whether it be fear or family history of what they saw, to help create a vision of the opposite of that for the individual to keep them motivated. But then, the practitioner side of me is trying to bring success to them. And that means that you have to build self-efficacy in the patient. So they need to understand at some functional level what is going on with their disease state. And I think these tools can help them to understand the key markers that we're looking at, and how their choices, their their decision to ride their little bicycle while they're at their desk or whatever the case may be, go for a walk after they eat. How these things tie into measurable outcomes, and this is the nice thing about these devices. They are measuring some type of physical change within the body, and we can tie it into those behaviors. So, I use every tool that I can get my hands on, whatever device they're willing to use. And then, I don't work with too many psychiatric or epileptic or cancer patients. I really do focus on the metabolic side. So I am dealing with all of that surrounds insulin resistance, and I have to help them understand their condition through other surrogate markers, even ones that don't use devices, like hunger. Many people that come to me is highly insulin resistant, showing signs of prediabetes or severe metabolic syndrome. They're shocked at within a week of changing a few habits, how they are no longer hungry, and they can now time restrict their eating, and this really helps them. So all of these inputs that we can take are really important. And I think the biggest problem for many usual care practitioners is they have to change their model of care. And one of the things I mentioned in my talk was considering using people like me or other auxiliary staff people to help you monitor, so that you don't wait 6 months to find out that the patient was trying but was unsuccessful because they didn't have the skills or the education to really understand what eating healthy meant. So I think these devices are here to stay. They are the future. And if you look at all of the trajectory in healthcare, making it easier for the practitioner to get information has always been a good thing.
Thanks so much. And I love, what you talk about, using those tools, using that as a motivation to get the patient or the client to start thinking for themselves. Now, I know this is about devices and technology, and I really love all of that. I thrive on it. But being that type A person myself, I got burnout from testing on myself. And so I always want to bring the discussion back to this point, which is behind all of this is a human being. It is a person who has work pressures and relationships to sustain, and a job to do, and has to self-care and all of these things. And while these devices are absolutely necessary in people who are struggling or who dealing with something, I think they're necessary. You can get away with more archaic versions of testing, but while it can be extremely helpful, I just want to make that point that people are afraid of the finger prick and the pain, and then the testing, and they feel like they're becoming like robots. Do you have anything to say about that, Franziska?
Yeah, I think this is a really great point. There can be testing burnout. It will really depend on the person, how often they need to test. If they are managing a serious condition where they need to be in a deep state of nutritional ketosis, then testing blood glucose and ketones every day is important. But for many people who have metabolic disease, they only need to test often at the beginning to confirm what they need to do to maintain a good metabolic state and to figure out what's working for them. And then they can test periodically and occasionally if they feel like they're slipping. So I don't recommend getting, too bogged down in over testing. And this goes along with wearables as well. It really depends on the person and how beneficial they find them, but it's easy to get obsessed and it's easy to get burnt out. So I think that's another thing that the healthcare provider, nutritionist, coach, whoever is working with the patient needs to assess is how helpful is all of this testing, and do we need to scale it back a bit if they're testing too much? It really is. I think the biggest thing about this is the ability to personalize. You can't do that when you're seeing someone every 3 months, but when you have an ongoing relationship with them and communication, then you can see what's going on and you can make sure that you are giving them the very best support and advice so that they can achieve their goals without getting too obsessive about the numbers.
Thanks for that. Yeah. So, I mean, let's keep it real, because otherwise you're going to be that family member at the barbecue. That's the one who tests all the time. She's always poking herself. And, there's a stigma. And really, we weren't designed. We've managed so long without testing. But it's just important to realize that we got to this point of ill health with bad food, bad habits, and not moving enough. We have stopped moving as much as we used to. We know, and the people watching this will know, but it's important to stress that it has happened over a period of time that the global population has become sick from consuming what is detrimental to the body and not supplying what the body needs for metabolic health. So Franziska, when you have a client, they've come to you, they were really sick, very not knowledgeable about their personal kind of risks and what triggered or what pushed their glucose up, what took the ketones down, this kind of metabolic mayhem. And now they've been on a journey, they've used these devices to learn about their bodies, bearing in mind that we are very not flexible, but we're constantly changing. Our environment is changing. And so it is important to periodically test. But let's talk about metabolic flexibility. Are there any specific patterns and a period of time when your client or your patient has been eating for themselves, whatever that is, and their weight is stable, their blood glucose is stable? What patterns do you look at to assess metabolic flexibility? And then are there any potential red flags that you would watch out for in the data?
So you're saying if all of their markers are okay to assess for metabolic flexibility?
Yeah.
Well, I would say just how quickly they can go from, having, if they are truly metabolically flexible, from having a few extra carbohydrates, how quickly they can get back into ketosis and their blood glucose levels get back to normal. Also, how do they feel? If the biomarkers are great, but they're not feeling well, then that's a sign that something is not right. So I really do try to take a holistic picture and not just look at numbers. See how people are feeling and also how they respond when things are changed, when they travel, when, how quickly that they can get back to their baseline of health if they've achieved that baseline of health. Or maybe they just need to, something has changed in their body and they need to switch things up a bit in order to really feel their best and perform their best. So I think it's constantly like reassessing and mainly going on how, how they feel. If all the biomarkers look good, how just looking at other things that aren't necessarily you're able to see. And again, this comes from the communication between you and the client.
And what are we looking at time-wise for getting that ketone back in? We're looking at under a few hours. Are we looking at under like 6 hours? That's a bit too long in my book. What kind of time frames are we getting?
Well, ideally, you should be able to get back within about 3 hours. But, if it takes a lot longer than that, then it can be a metabolic flexibility issue. Or maybe you're just not quite there yet in being able to have that amount of carbohydrate at a time. And you should try with a smaller amount of carbohydrate and test and kind of work your way up to it. And of course, how active you are can make a difference. Also, sometimes people have a low-grade illness or something they're not aware of that's actually also affecting how they feel and how quickly they can kind of bounce back into ketosis. So many different things can be going on. And I think what's really important is looking at the overall pattern. And if overall pattern, they're doing well, things are improving both in the markers and also the way that they feel. That's a good sign. And if there's just an anomaly, talk about it. But if it's not happening again, then just moving on and not trying to make too much of, a term thing.
I love what you said, and you've always brought it back together, like Peter as well mentioned, how are they feeling, the person as a whole. So I think that it's so important to realize that even if you've got type 2 diabetes, that it is reversible on a personalized diet for you. And it's important that to know that this is a journey. And if we didn't track, right, the person would look at weight. And if you just use weight to go by, am I successful? Like Peter said, you want success. Am I experiencing success or not? There are some vulnerable times, like we know, in perimenopause, when the estrogen levels drop and the progesterone levels drop, that's a vulnerable time. We also have the adolescence stage. That's a vulnerable time. So if we weren't testing, there would be just some mayhem going on that just throws people off. So we actually are a little bit out of time, but I just want to ask one question to both of you, because there are a lot of practitioners who have been practicing in the old model. They've learned about the ketogenic diet. They want to start integrating this. So if you've got a busy practice and you don't want to manage patients like this, then we have coaches trained by Nutrition Network. Peter is somebody that we highly recommend that you work with, and his experience in exercise medicine is phenomenal. So you get like a complete package. But Peter, how would you, to a doctor or a coach that's listening that wants to use this model to start remote tracking their clients, their patients, what should they start with? What's the bare minimum? What can they ask their clients to do to get started on this journey?
I guess it would depend on the patient and the type of doctor, but from my experience, what I've been doing with some physician is contracting out as their auxiliary staff, and then I provide exercise prescription. I assess the patient remotely and then provide some level of exercise prescription, and the provider then can bill in certain situations. And then I have a concierge physician who has me working with his patients in the same manner, except I work on instead of a code driven basis, I work on an hourly basis. So I guess you have to want to do it first. And then if you do, there's ways that you can implement that. And then what you implement will depend on the patient's need and the type of practice that you're having. If you're obviously dealing with diabetics, a CGM is fantastic. A scale is fantastic. If you're dealing with a heart failure patient, blood pressure and a scale are critical. So, understanding what type of information you want as a professional, what type of information the patient can provide easily to you so that they don't get burned out, and then explaining to them why that data is important and what they need to be aware of and what you're going to be looking for in that data will hopefully build compliance and safety and a faster turnaround time and keeping people out of trouble.
Thanks, Peter. Franziska, how would you suggest to your doctors, coaches to use Keto Mojo? How do they contact you? What do you provide? How do they use that to remotely care for their patients and clients?
Yeah, thanks for that question. So Keto Mojo has a dual blood glucose ketone meter that we provide on our Shopify website and also on Amazon. That is a cost, and also a one-time cost, and then there's strips that they purchase. But we have the MyMojo Health app where they can track their data and see it and compare. And this is something that patients like to do, is kind of do a sort of gamification and see how they're doing 1 week to the next, 1 month to the next. They can be really helpful for them, and they can look at their graphs. If they're working with a provider, a coach or a doctor or a dietitian, that dietitian can, or any healthcare provider can sign up for a MyMojo Health Practitioner account so they can see all of their patients' data in real time. And they can see notes that the patient makes. They can have a discussion back and forth. This is free to the practitioner. And they can also export graphs. They can use it in clinical practice. We are integrated in with other hospital systems. So this can be, I think, a really valuable way of integrating continuous remote care with your patients and making them feel supported. And yeah, that's ketomojo.com is our website. And you can also pass my contact information on if people would like to talk to me directly. But we also have great customer support and additional resources on our site.
Thank you so much. And thank you to all of you for listening in. Thank you to Peter and Franziska for this phenomenal discussion. We have covered so many things, but what I love is that key to it is respecting the patient in front of you, the client in front of you, and really just personalizing care for success. And you know, the fact that all of this is giving, these devices are giving that that sort of power back to the client is really where we want to be. And so thank you so much for your insights today.
Thank you very much.
And if you found today's topic interesting, if you're intrigued, I invite you to join us for the full Mastering Metabolic Metrics training. It's launching at the end of July. Whether you're new to therapeutic carbohydrate restriction or whether you're already certified, this is going to sharpen your ability to interpret the data and to fine-tune your interventions and to be able to deliver more personalized and effective care. So stay connected with us, stay curious, and keep testing smarter. Thank you both so much, and thank you to all of you who've joined us today. Bye-bye.
Bye.
Thank you.
Thank you.